Replacement of all or part of ureter by intestine segment, including intestine anastomosis. The physician replaces part or all of the ureter with a segment of intestine. To access the ureters and intestine, the physician makes a midline incision in the skin of the abdomen and cuts the corresponding muscles, fat, and fibrous membranes, fascia. After dissecting an isolated segment of intestine, the physician reconnects, anastomosis, the divided intestine to restore bowel continuity. The physician dissects and removes the diseased or defective ureteral segment, replacing it with the intestine segment. To provide support during healing, the physician may insert a slender tube into the ureter. The physician inserts a drain tube and performs a layered closure. Replacement of bone flap or prosthetic plate of skull. The physician replaces a bone flap or prosthetic plate of the skull. The physician incises the scalp and retracts it to expose the dura. The bone graft or prosthetic plate is placed over dura to correct the defect. The bone or prosthetic plate is stabilized and the scalp is reproximated and sutured in layers. Replacement, including removal of existing device, osseointegrated implant, temporal bone, with percutaneous attachment to external speech processor/cochlear stimulator, without mastoidectomy. With mastoidectomy. Generally, titanium fixation plates are not removed after osteosynthesis because they have high biocompatibility and high corrosion resistance characteristics. However, various problems, i.e., improper electrode insertion or migration, device failure, serious flap complication, may require removal and replacement surgery of the osseointegrated implant. To remove the implant, the physician opens the skin at the temporal bone at the site of the original implant and removes any fibrous tissue sheathing the implant. The existing pedestal and electrode array are removed and replaced. Report 69717 when the procedure is performed without mastoidectomy. Report 69718 when the physician drills out the mastoid cavity to remove diseased tissue. Removal and replacement of all components of a multi-component inflatable penile prosthesis through an infected field at the same operative session, including irrigation and debridement of infected tissue. The physician removes and replaces a multi-component inflatable penile prosthesis and irrigates and debrides infected tissue. The physician makes an incision using the same penoscrotal or infrapubic approach as the original procedure. The existing subfascial pocket is used to place the reservoir, as well as the pump/activator mechanism, which is placed in the existing scrotal pocket. Any infected tissue is debrided and irrigated with an antibiotic solution. Sutures are placed to prevent upward migration, the tubing is filled with fluid, and the physician makes the connections between the tubing of the pump and reservoir and the tubing of the pump and cylinders. Before the wound is closed, the prosthesis is cycled to check proper functioning. The corporotomy is closed by suture. Removal and replacement of non-inflatable, semi-rigid, or inflatable, self-contained, penile prosthesis at the same operative session. Under general anesthesia, the patient is placed in a supine or lithotomy position and the physician makes an incision using the same approach, i.e., penoscrotal or distal penile, as the original procedure to remove the non-inflatable, semi-rigid, or self-contained inflatable penile prosthesis and to insert a replacement prosthesis. An incision is made into the corpus cavernosum, the corporal tissue is dissected, and the prosthesis is removed from the corporal body. The wound is irrigated with antibiotics and the replacement prosthesis is advanced to the midglands and introduced into the corporal space. Once implanted, the wound is again irrigated with antibiotics, and the corporotomy is closed by suture. The subcutaneous tissue is closed by suture and a dressing is applied to the incision. The bladder is emptied with a catheter. An indwelling urethral catheter, if used, is removed on the first postoperative day. An incision is made into the corpus cavernosum, the corporal tissue is dissected, and the prosthesis is removed from the corporal body. The wound is irrigated with antibiotics and the replacement prosthesis is advanced to the midglands and introduced into the corporal space. Once implanted, the wound is again irrigated with antibiotics, and the corporotomy is closed by suture. The subcutaneous tissue is closed by suture and a dressing is applied to the incision. The bladder is emptied with a catheter. An indwelling urethral catheter, if used, is removed on the first postoperative day. Using corporal incisions, the physician is able to remove the prosthesis. A colposcopy may be performed to ensure all fibrous elements are excised, and a replacement prosthesis is implanted. Any infected tissue is debrided and irrigated with an antibiotic solution. The corporotomy is closed by suture. The subcutaneous tissue is closed by suture and a dressing is applied to the incision. The bladder is emptied with a catheter. An indwelling urethral catheter, if used, is removed on the first postoperative day. Removal and replacement of inflatable urethral/bladder neck sphincter including pump, reservoir, and cuff at the same operative session. The physician removes and replaces an artificial sphincter, including pump, reservoir, and cuff, used to stem urinary incontinence. In male patients for whom the incontinence is caused by anything other than prostatic surgery, the prosthesis is accessed through a subpubic incision. In female patients, the sphincter is accessed through a suprapubic incision. The sphincter and pump are examined, removed, and replaced. The bladder neck circumference is measured and a cuff of slightly larger size is chosen and positioned around the bladder neck. A space is created below the skin low in the scrotum and the control pump passed into this position from the subpubic incision. The pressure balloon is placed in a pocket behind the rectus muscle on the same side as the control pump. The physician injects fluid into the pressure balloon and the connections are permanently established. In females, the plane between the bladder neck and vagina is dissected.